Hi everyone, I'm Nobert Pesztenlehrer, Head of Ophthalmology at Pécs County Hospital, DOR, Hungary. I'm also a big fan of the digital operating room and how it's evolving in ophthalmology. Today I'm talking about where we are in modern ophthalmology with the digital operating room. Among other things, I'll take you through my digital operating room setup. With the traditional workflow, we've got the following problem that since we are implanting many toric IOLs, the preparation of the patient for surgery takes a long time. So it slows down the workflow in the operating theater. On the other hand, organizing all the papers and measurements takes time, and there's a chance for changing the papers of the patients, and that this could lead to misimplantation, wrong implantation of lenses in patient. Evaluation of the results postoperatively is slowed down also. We have a lot of paperwork. Intraoperative visualization with the traditional microscope was quite fine, but teaching the colleagues and making high-end videos on surgeries was quite difficult, and also the patient invests a lot for toric implantation, and they want to have good results as well as the surgeon. And that was the major reason. That's why we changed for the digital version. To be honest, I had a cervical discus hernia in 2018. I had a surgery, and I had to realize that the way using a traditional microscope is not good for me for the future, and I started to operate with this system, and it was so relaxed, no pain at all, even after vitreoretinal surgeries, which took 1.5 hours, 2 hours even in difficult cases. The staff likes the system because they see that we are moving forward, development is there, and they were proud to be part of, to use a high-end technology in the operating theater. We are using the Alcon platform, and starting at the beginning, we've got network link SOCT called Argus biometer. It is connected to 8 workstations all over the department, and we can do the planning at every workstation, and then we can transfer it in both operating theaters where we have both set up for digital marking and for 3D visualization. After relaxed working, all data are exported back to the biometer and evaluated later. But the workflow is so seamless that it's no issue to return to the old analog way. If you're using the digital version, you should recall the data of the patient in the operating theater, which is sent there by the network or by Wi-Fi. Your performance is triggered and helped by the digital capabilities of these combined systems. Honestly, the transparency using this 3D visualization, the digital visualization during the surgery, spurs the surgeon to a better and better performance. So it improves your capabilities since you are controlled by your surrounding. And of course, the precision has been increased by following all the situation on a great screen. It's very comfortable for the surgeons, to be honest. Very easy to teach and correct the residents' way of learning and way of performing surgery. The patients are amazed by the technology we show them, and after the surgery, when they see the great screen of the 3D monitor, they are convinced that they were at a very good place, which was high-end in technology. The patient outcome is significantly better, and the predictability of the results is much better than previously, since it's more precise, especially implanting toric IOLs, where the alignment is shown by 1 degree instead of 10-degree steps with a manual mark. To a high efficient working at our department, it was not an issue on the costs, but Generation X and baby boomers were less capable of changing their way of surgeries. but Generation Z is and Y are very, very capable of using this new technology. There was a fear of presbyopia by other colleagues. They weren't able to use this new technology, but this fear was grounded. There's no ground for it because it was more comfortable for them to use. There was a colleague of mine, a consultant one, who didn't want to use the Ingenuity system, and it came out he has gotten a cataract on his one eye. I did his surgery, and from that moment on, he was also a fan of the Ingenuity. So you need really 3D binocularity to use the system, but since you have it, presbyopia or age is not a limiting factor. So everybody accepted this new technology in both operating theater, and this is very important. So we shouldn't forget a patient when we are using new technologies. First of all, it should be the use for the patient. They need very, very good postoperative outcomes, and that's what the digital system could provide you. Better outcomes for the patients and better, more reliable performance. My advice for using or trying out this system is do not have fear on new technologies. Be open-minded, be transparent. Don't give up after 1 or 2 attempts. You will feel after a while. The learning curve is very short using 3D visualization, for instance. But if you are convinced and you have a good knowledge and a good practice, you can get familiar with the system very, very soon. And that's a good way.